you can save people's life. And very fortunate that out of 86 patients, you didn't have any mortality. It's very good, and it's very, if you say 86 cases in a year, it's a very, very high number. I mean, how is it in other institutions which have this?
Coincidentally, we have data from our state. Ectopic pregnancy incidence and outcome. It is already published in, it was done by one. And incidence is about 2.2% in our institute. 2.29 exactly. And out of this, we have dissected about the clinical presentation in this one. Forget about other, but I want to tell about one patient in 2022, we have mortality one. That patient was because of delay basically in shifting the patient from casualty and medicine, and patient was diagnosed with late. So we have one mortality case. And other thing is all the same research. That about the casualty and diagnosis early, and early treatment is the key decrease the mortality and morbidity of the patient. So actually, emergency people, they must know this. We want to convey this message.
In your analysis, it would be nice if you could have analyzed the individual cases just to find out what could have been the contributing factor to ectopic pregnancy that have been given us some information in counseling and other things. So if that has not been done, maybe you can do it. Individually go and analyze.
The data we have analyzed, out of that, self-medication is the number one. They take self-emergency contraceptive pill as a regular contraception. The data we have,
married, unmarried.
Basically, unmarried or married, they are living in relation days to day. And like emergency contraceptive, they take as a regular contraception. That one incident is very high in those group of people. Of course, they have an logic on that, why it is high. That we have found.
So during our time, almost all the cases of ectopic pregnancies were dealt by surgeons only. I remember my second posting was at Jiro. The day I stepped down from the bus, I was immediately taken to the hospital and shown a lady who was pale like pepper, had a history of abdominal pain and also menstrual bleeding. So just by clinical examination, even I didn't have a urine testing facility also. Ultrasound was not there. We just took her and then without even anesthesia, opened the abdomen, caught hold of the bleeding point and said. Similar thing happened here also, even subsequently when I was posted here. So now you have got all the facilities. So most important thing is I think the high index of suspicion. Any abdominal pain in a reproductive age group, and you should always first rule out ectopic pregnancy. In male again, I think I don't know the students may be here. In male again, any abdominal pain, you must examine the genitalia, especially testes. So we have missed out here. And now, why we have been all insisting on the universal use of ultrasound. Ultrasound will be the one key factor which is a game changer in this kind of case. So all the cases you have saved and then you have managed properly, it is maybe because of availability of ultrasound everywhere. Now we have two ultrasound in the casualty, and your department has. In fact, every department should have an ultrasound in the department. So therefore, I think the 5 days of a patient with an ectopic pregnancy, first ectopic pregnancy, kept in surgical ward for 5 days, it is really not acceptable in a clinical like this. So I think this should not happen. And that's other thing is when we just use beta HCG as the indicator, of course, in case of pregnancy, it will be very, very high. But also must teach the student that there are other sources of beta HCG other than the sincere tropoblasts, like even some tumors can produce HCG, like liver tumor, colon tumor, and especially, of course, in male, testicular tumors can produce high quantity of HCG, and even pituitary tumors. So these things, and anyway, it was a very good presentation, but to make it more interactive or whatever, little bit of your surgical laparoscopic picture or something, small snippets would have been nice to make it more
acute pain abdomen, and then again after few days she will again develop pain abdomen, maybe vaginal bleeding, and there will be on examination there will be abdominal mass, tubo-ovarian mass on bilateral examination as well. And if we do an ultrasound, we will get tubo-ovarian mass in the exam. And opening, there was a lot of elevations. One case I personally have done, there was a case of chronic ectopic. There was a big ball of mass. There was elevation, momentum, and intestines were also added to the ectopic mass.
But it is not the
Yes, to complete my anecdote. Sagali. Then going to what is it called? Sangram actually. Sangram पर पहुंच गया था. On the way Sagali, not Sagali, Palin, na? Is all the way Palin. So I halted there. I went to the primary health center. So I was told that one teacher, school teacher, she went for a birthday party last night, and she is having abdominal pain and severe abdominal pain. Please come and see. So after this lunch break, I went inside the dark room. The lady was lying. I felt her hand. It was very cold. I perfect abdominal tenderness. So I brought her outside the dark room, and so it was pale like paper. And she had a history of tuboplasty because she had only one issue. All put together, I say this is ectopic pregnancy, and also she had the vaginal. पालिन से मैंने गाड़ी मंगा के उसको आहिस्ता IV ड्रिप नेक्सोस लगा के लेके आया. So in the every 3-4 kilometers we stop the vehicle, check her pulse. If the pulse is low, again pump in fluid. We managed to bring her to Zero Hospital alive. And straight went into the OT inside. No anesthesia, just open the abdomen. Again. Survived. And she is the mother of our doctors. She is a very senior doctor. And that lady is still alive. So it was like that. So I think it is
Gujarat, it was long back. What happened in the evening, a lady came who was around 40 years, just complaining of mild abdominal pain in right hypochondrial region. There was no tenderness, no guarding, no rigidity. I just suspected it might be an ulcer or maybe an intestinal colic. Just gave her anticholinergic drug dicyclomine, an anti-ulcer drug pantoprazole, and asked her to go because there was no symptoms, no sign, nothing at all. Somehow the surgeon was passing, madam. He just told me they went and proceed immediately for sonography for her. And when the sonography was done, it was a free fluid in the pouch of Douglas and diagnosed to be ectopic. On the very same day, within an hour, she was operated and there was some 1.5 liters of blood. So just I want to ask you, because many times, even as a medical officer, we come across patients who have got abdominal pain, but there are no signs at all. And even I asked her that is there any history of chances of pregnancy? She told no, not at all. So madam, what are the various things by which we can suspect that it might be ectopic? And then surgeon told that if he would not have come to that place, then finally the dead body of her would have been coming. So that was something which even I felt. So can you just tell me, madam, how we can diagnose or what could be the index of suspicion that it is pointing towards ectopic? Because in general, many times abdominal pain, we just give anticholinergic drug and anti-ulcer drug in the routine practice and we ask the patient to go, because not necessarily for every patient we are proceeding for sonography. Thank you.
The woman was of 40 years old, right? So ectopic is mostly common in 35 to 40 years of age due to decrease in hormone. So there is decreased peristalsis of the tube. So there is less, the transfer of the ovum gets stuck in the site of fertilization. So ectopic is more common in that age group. So if there is no investigations available, only from the history itself also. Many of the time here we do not ask about menstrual history. Only I think many people only ask about the menstrual history. So you have to ask about last menstrual period and how was the menstrual period. Was it regular? Was it scanty bleeding? And if she had the hemoglobin of 1 to 1.5 liter, then she will have definitely have tachycardia, hypertension, or maybe pallor, or maybe tenderness in abdomen. Maybe she might not have as typical symptoms. But only just by history itself and examination, we can, and also there always has to be high degree of suspicion. If it's a reproductive age in the group, if a woman is in that group, we definitely have to ask for menstrual history, and if there is a doubt, do a urine pregnancy test, as it is 90 to 99% accuracy rate, and also it is easily available and cheap.
Suddenly she developed pain and ultrasound showed some collection. We kept on asking her, did you have any sexual contact? She is unmarried. So family said, मेरा तो कोई boyfriend भी नहीं है दूर तक. So हम लोग most probably urine test में नहीं कराया सच के. When they operated, it was ectopic pregnancy only. It happens like that. So this is very fallacious. Asking nobody. And one of our very senior gynecologists herself, while she was operating, suddenly she collapsed in the operation theatre. ऐसा भी होता है. Yeah. The last question I want to ask is, you said in your presentation when you aspirate the fluid, I mean this to be unclotted blood. Yeah, yes. Corpusynthesis you do is unclotted blood. Why is the blood not clotted?
Findings, it can be a fresh bleeding which will have a list of differential diagnosis, and if it's a very recent ruptured ectopic, then the blood will be clotting, blood can be aspirated. But if it's a ruptured ectopic but it has some time has been passed, then I also searched in the net that why is it non-clotting. Well, there was some. So there are. If there is bleeding, it gets clotted. There is a, because when we operate right on laparotomy, there is some clot, and also there is some non-clotted blood. So the clot has already been formed and has already been formed. All the fibrin has already been used. So the free blood which the fibrin is not there anymore. So those blood, if we aspirate in synthesis, that blood will be non-clotted. So that is what I found. I also said